Good afternoon, everyone, and welcome to the SCAGO Summit 2023. Great to have all of you here. My name is Sanjeev Wadhwani. I'm the head of prescriptions business at Galderma, where we focus on bringing innovative products and therapies for patients with dermatological conditions. I'm also the chair and of the board of directors for SCAGO, and I've been part of this organization since 2020. I'll be moderating today's session, Clinical Track 2A. If you or your members of your network would like to refer back to the session or any information, please note that the session is being recorded and will be posted on the SCAGO website, and it can be viewed at your convenience. In this session, we'll be hearing from Dr. Christine Lamontagne and Dr. Jacob Pendergrast, who I'll introduce shortly. But before I do that, let's just go through a few housekeeping rules just to make the session as efficient as possible. We ask that your questions or thoughts, can be addressed in the latter portion of the session once the presentations are over. You can raise your hand or you can put your questions in the Q&A box, which you'll find at the bottom. The other thing is the microphones will be disabled for all the attendees to be mindful of the presenters. If you'd like to ask a question, like I said, please put it in the chat box and that can be taken, towards the latter part of the presentations. There is a translation functionality that's also provided. If you look at the bottom of your screen, there is a button that is available in the more with the three dots. It's called captions. And if you select that, you can choose the language that you'd like to listen to the session in, and just make sure that's enabled, and then you can listen to it in your local language. Also, just please be respectful of the language in the chat, no profanity or inappropriate images or posts. Please don't post any material that's, unrelated to the presentations for this particular session, and keep the discussions and comments as much on topic as possible. So really a big thanks to our presenters, and thanks to all of you for your understanding and agreement and engagement. So with that, I'd like to just add one more disclaimer that any information shared in the summit does not constitute medical advice. And with that, we can get started. So I'd first like to introduce Dr. Christine Lamontagne. She's a pediatric anesthesiologist, pain physician, and clinical researcher at the Children's Hospital of Eastern Ontario in Ottawa. She's medical director of the Chronic Pain Services, where she has led the creation of an interdisciplinary chronic pain clinic, and she has co-chaired the development of the Ontario Pediatric Chronic Pain Network in partnership with the Ontario Ministry of Health, and continues to work at improving access to interdisciplinary chronic pain care for all children. She has developed national recognition for research in acute and chronic pain as co-investigator and collaborator on the CIHR-funded strategy for patient-oriented research, Chronic Pain Network. Her current research focuses on identifying strategies to improve acute pain management in order to prevent the development of chronic pain and evaluating the role of different approaches in improving pain outcomes for chronic pain patients treated in interdisciplinary context. So with that, I'd like to transition to Dr. Lamontagne for your presentation. If you don't mind sharing your presentation, please.
Thank you so much for the kind introduction, and I'm very happy to be here today. So today I will talk about when acute pain becomes chronic. So I hope everyone can see my slide. Yes. Okay, so I have nothing to declare, no conflicts. So today I thought I would start with a case scenario of a case that we've similar case that we've had in our pain clinic. Then try to answer the following question. So what informs pain management for sickle cell disease, and how does acute pain become chronic? What central sensitization, especially in sickle cell disease? And should sickle cell disease pain be treated through a different lens, like through the biopsychosocial lens? And how can you advocate as a healthcare provider or a patient? How can you advocate for equitable pain care? So this is our case scenario. So we have a 13-year-old female who's diagnosed with sickle cell disease when she had her first vaso-occlusive crisis. pain continued even after this vaso-occlusive crisis, despite the lack of evidence of any other complications from her sickle cell disease or any further vaso-occlusive pain. She had been thoroughly investigated and her hematological care had been optimized. Uh, the patient was still requiring long-term opioids, morphine twice a day with some intermittent dosing. She had had multiple emergency department visits due to severe pain, but there was no evidence of hematological cause for the pain. She was sort of labeled as a drug seeker from the get-go, but unfortunately, this child was not able to attend school. She spent most of their days in bed, and she had very limited ability to interact with friends or families. So she was referred to the interdisciplinary chronic pain clinic about after 1 year. She was assessed in an interdisciplinary fashion by our pain physician, our physiotherapist, and our psychologist. So we found that the pain had started after that vaso-occlusive crisis. It was fairly diffuse. It was kind of myofascial in origin, and there was some sensitivity to light touch. She rated her pain anywhere from 5 to 8 out of 10. Seemed to be aggravated by physical exertion and relieved by rest and heat. And it was associated with this fear of death. She had had a family member that had passed away from a sickle cell disease complications. So she had insomnia. Again, she was not able to go to school. She couldn't play basketball. She couldn't see her friends. She felt very anxious, very sad, very invalidated over the last year. And there was this fear of the pain, fear of death, and she's crying in our clinic. So we developed an individualized care plan based on this 3P approach. So 3P is like pharmacological, physical, and psychological. From a pharmacological point of view, we decided that we would start some gabapentin to allow us to slowly wean this long-term opioid. We started duloxetine to treat the depression because our mental health providers felt there was depression. And then we used our magnesium bowel protocol to treat the myofascial pain, some magnesium cream, some celecoxib, and some baclofen as needed to help as rescue. And then for a physical point of view, we've prescribed some physiotherapy with some myofascial release. She had some massage, some heat. We did some yoga, and she had a home exercise program that included stretching, aerobic, and strengthening. From a psychological point of view, we recommended some cognitive behavior therapy to work on the fear, on the thought processes around the pain, with some goal-directed approach. We also involved the parents in this approach. We were also liaising with the school through a school letter with an individualized pain plan to facilitate this progressive reintegration of the youth into school. And this was done with our occupational therapist. So about a year later, this patient was now back to school full time. She was playing basketball. She was seeing some friends, and her mood and pain had dramatically improved. So what informs equitable pain care in pediatric patients with sickle cell disease? So we have different guidelines that were all published between 2020 to 2021. We have the Canadian Pain Task Force report. We have the Pediatric Pain Management Standard, which was a joint venture between Health Standard Organization and the Solution for Kids in Pain. We have our guidelines for sickle cell disease management for acute and chronic pain published in the American Society of Hematology. And we have the World Health Organization who published some guidelines on the management of chronic pain in children. So what do these all have in common? They have in common that they all speak about equitable, person-centered pain care, all speak about the importance of, in the acute care setting of prompt assessment and reassessment of the pain, and having an individualized care plan that can include, may include in this case, in sickle cell disease, use of a multimodal strategy, so non-steroidal anti-inflammatories, maybe some IV opioids or PO opioids, and as well as maybe some low-dose IV ketamine infusions, which we commonly use here. And then it speaks really about the importance of having this individualized care plan, not only on the acute front, but also on the chronic pain management. And that this may also include some non-pharmacological approaches like TENS, massage, yoga, guided relaxation can be involved in this pain plan. Okay, so I personally use this diagram to explain to patients and their families sort of the difference between acute and chronic pain and the process of central sensitization. So let's start with acute pain, so which is initiated usually by a painful event like a vaso-occlusive crisis that will stimulate the first pain nerve that we see in red, which connects into the dorsal horn of the spinal cord to a second pain nerve. And that connection is called the pain gate. So here is the pain gate, as you see on my slide. And the pain signal continues then and connects to the brain, but that pain gate is where the pain signal gets either increase or decrease in intensity. And the way that the pain connects to our brain, if we look at all these areas in pink, there are essentially our emotional centers. So that is why pain is not only a physical phenomenon, but is also an emotional phenomenon. So in other words, pain and emotions kind of travel together in our nervous system. We have also these other nerves in blue on this picture that are called the descending inhibitory nerves, which come from the brain down to the pain gate to close that pain gate and resolve the pain. But in chronic pain, there's no more sort of painful stimuli like a vaso-occlusive crisis. There's nothing that stimulates the nerve peripherally, but the pain nerves are still active. They're still sending that signal to the brain. And part of it is because those descending inhibitory signal, the blue nerves, are not working properly. And they don't work properly because of what's going on in the brain. And this is what we call the process of central sensitization. So it's basically the pain nerve that it doesn't get turned off and gets amplified instead and keeps sending this signal to your brain. So it's basically a malfunctioning of the pain nervous system. So interestingly, the blue nerves, or these descending inhibitory signal, are really dependent on what goes on in our brains in terms of our thoughts and our emotions, because they're directly linked to these emotional centers, which we will see in our next slide. So this is how does an acute pain become chronic. So initially we have our tissue damage or inflammation going on. We have different risk factors. And then we're going to get into that pain spiral where we kind of rest or have more passive coping, which was limit our activities and lead to weaker and tighter muscles, which leads to physical deconditioning and also psychosocial deconditioning. And then there's further withdrawal from social and physical activities, which leads to anxiety, depression, anger, which then further limits our activities. And then we can see that we have this pain-centered life where everything is centered around the pain. The pain kind of decides if we're going to do certain activities or if we're going to go out of the house. And often myofascial tightness or pain often involved in this pain spiral. Okay, so what are the risk factors for acute pain to become chronic in sickle cell disease? So we talk about the pain catastrophizing as one of the major factors in this transition from acute to chronic pain. And what is it? It's sort of the negative thoughts that we have around our pain. So thoughts like my pain is terrible, it's awful, I can't stop thinking about it, I'm afraid of it. So these are all sort of awfulizing thoughts around the pain itself. In pediatrics, also parental pain catastrophizing also an impact on this chronification of pediatric pain. And then we have the epigenetics, which is sort of a mixture of the behaviors and the environment and how that can affect the way that our genes work. We have anxiety and depression, which also are risk factors, poor social support, inadequate acute pain control is also a risk factor. So we know that it's important to treat acute pain properly to prevent the development of chronic pain. The type of pain, so neuropathic pain or ischemic pain, which is sort of the pain model that we have in sickle cell disease, really has a higher propensity to lead to chronic pain. Again, altering significantly these descending inhibitory signal, those blue nerves are going to be affected even more. And we have also stress and trauma, which will affect our emotional centers and cause hyperactivity of these centers and really lead to more propensity for this central sensitization to occur. And the fear avoidance pattern also is definitely, as we saw with our pain spiral, a risk factors for this chronification of pain. So this makes sense then, knowing that pain is the way that it is with all the connection between the body and the emotions. With the pain signal, it makes sense to talk about this multi-prong approach to pain management, where I call it the 3P approach. So it's this combination of some medication, a psychosocial approach with a physical approach, and teaching the patient to self-manage with a combination of these in these three approaches. So it could look something like, for a patient with sickle cell disease, could look like, okay, I'm going to do regular physical exercise or yoga. I'm combine this with some medication, and then do some mindfulness or cognitive behavior therapy to work on fear or how one conceptualizes their pain experience. So optimal pain care in sickle cell disease, I think, needs to be interdisciplinary, because again, I don't think that sickle cell disease should be treated only as a hematological problem. Pain is a biopsychosocial phenomenon and needs all these disciplines involved. I mean, there's no one size fits all, but each patient needs to have a sort of a tailored approach to their pain situation. And it can look a little bit like this, a combination of psychology, pain medicine, nursing, hematology, some family or social support, maybe some integrative health approaches in there, and physical rehab and social work as well. So that brings us to our individualized care plan, which again, our guidelines highly suggest this, and we're starting to use this here in Ottawa, but by no means we are perfect, and there's still lots of room to improve. But individualized pain plan are useful, and they've been the studies so far show that they deliver high quality pain care. They decrease time to first opioid in the emergency room department by almost 50%. They decrease avoidable hospitalizations in SCD and sickle cell disease. They decrease length of stay. They improve patient satisfaction, and they also improve patient-provider communication. So these should be developed with the healthcare providers in collaboration with the patient. So patient is really at the forefront of this. It should include all the disciplines that are involved in the pain management of the patient, and should be easily accessible through the electronic medical record, or it could be printed and carried by the patient. There's ongoing studies right now looking at some app technology to bridge this gap between patient and healthcare providers and hospital electronic medical records. And this plan needs to include pharmacological and non-pharmacological pain management, so that even the dosage of pain medications that have been useful in the past. For acute pain, it could be like low dose ketamine, the type of opioid, the dosage of opioids that were used, and this should be reviewed yearly by the provider and the patient. So in closing, how and this is in keeping with today's theme, is how can one self-advocate for equitable pain care in sickle cell disease? So knowing the guidelines, so these are all guidelines that are easily accessible on the web and freely accessible. Learning about the factors that lead to the chronification of pain and trying to see if we can modulate these. Treat the sickle cell disease pain through a biopsychosocial lens with this 3P approach. So combining pharmacological, psychological, and physical approaches in our individualized pain plan, and develop this and maintain this individualized pain plan as a tool to not only to self-advocate, but to improve communication and hopefully lessen this impact of provider bias and racism that we see still in pain care. So thank you for listening, and I'll be taking some questions later, and I've included here my email if anyone has any question or wants to reach out. Thank you.
Thank you, Dr. Lamontagne. Very nice presentation, and always good to learn different approaches taken in practice. And so I hope everybody, let's say, has good questions coming for you as well. I know we have a couple in the queue. And just a reminder for those who joined, let's say a little bit later than we started, we will move to the next presentation, but please keep your questions in the chat. Don't forget them. Please add them in the Q&A. And if at the time of the Q&A you'd like to raise your hand and let's say voice your question verbally, we can certainly enable you to ask your question that way. So thank you again, Dr. Lamontagne, and we look to the Q&A shortly. I'd like to introduce our next speaker, Dr. Jacob Pendergrast. He graduated in 1999 from Dalhousie Medical School and completed his training in internal medicine, hematology, and transfusion medicine at the University of Toronto before taking a staff appointment at the University Health Network, where he served as medical director of the blood transfusion services. He currently holds a cross appointment in the Department of Medical Oncology and Hematology as a clinician teacher, and has been seeing patients in the Toronto General Hospital's red blood cell disorders clinic since 2004. So Dr. Pendergrast, if you don't mind sharing your screen, I'll transition to you for the next presentation.
Okay. And is that showing the right screen, the slides and not the presenter view?
Not yet.
Okay, hold on, I can fix that. How's that?
Now it's in presenter view.
Oh, sorry. Okay.
No worries.
Was no?
Not yet.
Hold on. Okay, let's see something else. It says screen sharing is paused. I don't know. I've never seen that before. Let me try this again.
Yeah, maybe we just need to reset it. No worries. There we go.
All right, and that's the right display?
Correct.
Yeah.
Okay.
Yep.
Okay.
Perfect.
All right. Should I start?
Yes, please start.
Okay. All right. So again, thank you to the conference organizers for inviting me. You know, it was interesting. Christine and I were both asked to speak on pain management, and we had a lot of bit of back and forth about how to kind of divide that topic up between us. I think the way it kind of fell out, and it wasn't explicitly planned this way, is I think she gave a very good approach to sort of the patient's perspective towards pain management. And my presentation is really more sort of how doctors think about this, and I think, you know, the two obviously are you know, very important to consider for both doctors and patients to think about how each side is viewing this. But this is sort of more kind of like maybe sort of a more traditional kind of medical approach, and I think it'll be interesting, I think, for the audience to see what that captures and what it misses in terms of what the patient's pain experience is. So I don't have anything to declare. And in terms of my objectives, I'm going to sort of just try to create sort of a nosology or kind of a disease categorization of pain syndromes, with the idea that they have to be managed differently. Talk a little bit about prescribing practices for pain medications. And I'm not going to spend too much time talking about novel analgesic options, just for the sake of time, but we'll make some brief reference to that and some things that are coming down the pipe. So pain is, you know, obviously not the only thing that one needs to know about sickle cell disease, but certainly it is the major driver of hospital visits for patients who have that diagnosis. And, you know, the actual cause of a vaso-occlusive pain episode is bone marrow necrosis. And so I am sometimes called by physicians who ask, like, you know, I'm not sure, can I believe that this patient is in pain? And I said, you should always believe your patient. If you want objective proof, you can get an MRI scan of the bone that they say is hurting, and you will see that there's marrow necrosis occurring. But that's certainly not expected. In terms of where this is happening, it's typically the lumbar spine, the thigh bone, knees. Ribs can be a very dangerous place to have pain because of the effect it has on ventilation. Chest pain or sternal pain, important to distinguish that from pain involving the lungs, vertebrae, shins, skull, and then children when they are first crawling and have sickle cell disease will develop hand and foot pain syndromes or dactylitis. You know, the typical course of an acute pain episode is there is a prodromal phase, you know, then the tissue necrosis begins. That can be very painful. And then after the necrosis finishes, there continues to be pain just from the inflammation, whereby that necrotic bone marrow is being broken down and absorbed. So there is sort of an episode of sort of initial injury, and then there's a period of healing from that injury, which is also involves some pain. So patients will typically say that they can feel it developing. It starts off as sort of numbness, aches, sort of a, you know, pins and needles feeling. And then the actual infarction of the bone marrow develops. That can be very painful. And then there's the post-infarctive phase where you're sort of recovering from that infarction. And then there's a resolving phase. Typically this happens or is played out as an outpatient. Patients go home managing the last bit of their pain crisis on their own. So I think, you know, that is like sort of what we call a simple vaso-occlusive pain crisis. And the support for that, you know, kind of crisis is typically you just provide the patient adequate pain medication to get them through it, and then, you know, do what you can as an outpatient to see if you can prevent these crises from occurring. You know, get them on disease modifying therapy so that these crises don't happen as often. Look at environmental stresses and that sort of thing. But of course, it's never totally simple, and I think there's two major pitfalls when you're assessing a patient who's having acute pain. The first is not distinguishing a simple pain crisis from a complex pain crisis. complex, meaning that there's some signs of organ dysfunction. So you have to always be on the lookout for that, because that requires a different kind of management. And the other thing that's quite challenging is distinguish acute from chronic pain. And that's actually not always easy for the patients themselves to distinguish. If they're in pain all the time, some days will be worse than others. I think, as Christine mentioned, there are all sorts of modulators of the pain experience that might make it particularly unbearable on one day. That's not necessarily the same thing as having a second insult, like a superimposed vaso-occlusive pain crisis on top of that. So that can be quite tricky. But certainly when we talk about what chronic pain is, the typical definition is that it lasts 3 months or more past the time of normal tissue healing. So, if you had an initial injury that caused pain, and then the pain is still there 3 months later, then that means it's a chronic pain syndrome that has developed. In terms of how to manage sort of simple vaso-occlusive pain crises, there's no shortage of guidelines on how to do this. They all say basically the same thing, which is that you need to start treating the pain immediately. Like, the American Society of Hematology says that this has to be within an hour of arrival in the emergency room, not an hour from triage, but actually putting your foot in the emerge. And although, individualized care plans are very important, they will always involve at some point some degree of non-oral narcotics, either intravenously, subcutaneously, or intranasal. That can be supplemented with NSAIDs for a limited time period, and then very important to consider non-pharmacologic therapies, which can be really important as well. The narcotics should be given in small doses frequently, not sort of a maintenance dose that you give every 4 hours with a Q1 hour breakthrough. That's not really how you're supposed to manage acute pain. It's more sort of small doses given frequently, keep checking until the pain is brought under control. And then you can start stretching out the interval between the pain medication, and then you can start worrying about transitioning to oral therapies. If you can't get onto the pain under control with that initial frequent small doses, then you need to start looking at more complex interventions, regional anesthesia like nerve blocks, sub-anesthetic ketamine, patient-controlled analgesia. These things can also be of value in certain patients. There were recent guidelines developed here in Ontario, and they essentially say the same thing. There's a few more sort of Ontario-specific or Canada-specific recommendations. The first is that patients with acute pain should be coded as CTAS level 2, which oftentimes they aren't. They're given a lower priority, and as a result of that, they don't hit that target of getting analgesia started within 60 minutes of presentation to the emerge. They add the proviso that if they have been triaged, then it's 30 minutes from time of triage towards when pain is started. Again, start with short acting, not long acting, and be comprehensive. Make sure that it's not all about drugs, that there are non-pharmaceutical interventions to control pain as well. Often, healthcare workers who work in the emerge say, that's a really high bar, to be able to get patients started on pain medications that quickly in an emerge that is overflowing with all sorts of acuity, that are chronically understaffed. And certainly that's something to have some sympathy for. But it is also worth knowing that the longer you make a patient wait to get their pain medication, it's been shown the longer they are going to linger in the emerge. So you are ending up just, creating some of that backlog that you're suffering under. If you just get to these patients right up front, treat them aggressively and comprehensively right from the beginning, very often they can go home. But if you sort of leave them lingering, sort of half-treated, delayed treatment, they're actually going to stay longer. Very often they end up being admitted. So it's worth the investment of time to give these patients their full early attention right up front. In terms of how the different medications can be selected from, NSAIDs, should not be discounted as an important adjunct to narcotic therapy. In some cases, it's been shown that they can be equivalent to narcotics if you give them combined with acetaminophen. And so there have been trials looking at Toradol, looking at other combinations like ibuprofen and Tylenol. And these have been found to be just as effective at reducing pain as narcotics. Now, you can't stay on NSAIDs like Toradol or ibuprofen indefinitely. They do have injurious effects, but they can certainly help bring the pain under control so you don't need as much narcotic. And that's important because narcotics have their own side effects, both acute and long-term. Demerol or meperidine, this is not a drug that we encourage the use of just because it has metabolites that result from its breakdown after you take it that have all sorts of neurologic side effects. And some patients are particularly susceptible to these. So it's not a medication that we advise. There are some patients who swear this is the only thing that works for them, and it may be that some of those neurologic side effects in those patients are actually helpful. But in general, it's not something that we recommend because it does have so much toxicity with it. A drug that is in the same class as Demerol that does not have these same side effects is fentanyl. This unfortunately has a very short half-life, so you can't take it as a pill. It has to be either given as a continuous infusion, i.e. patient-controlled analgesia, or as a transdermal patch. And the patches can be effective, but you do have to be careful that unlike PCA, if you get too much of this as a patch and you fall asleep, it will continue to leach fentanyl into your system. So you do have to be careful not to overdose on this, and also to make sure that you have experience with it and that you are not alone when using it. Morphine is still the tried and true narcotic medication. It's still our first-line therapy for most patients. Hydromorphone is essentially morphine that is rendered slightly more potent, and therefore you don't need as much of a dose, but it's the same basic drug. And it's something that as soon as you can, you should sort of try taking orally so that you can establish while you're in hospital what an effective oral dose is, so you don't go home and switch from intravenous to oral the day you leave hospital and discover that the oral dosage you've been given is not enough. Once you have established what the effective oral dose is, and you have long-term pain management requirements, then you can start thinking about long-acting formulations, but that's generally not speaking something that you should be doing in the acute setting. Codeine is a medication that was marketed very aggressively by the manufacturer as being a good alternative to morphine because it has to be metabolized into morphine. And so the idea was that because there's this sort of metabolizing step that happens in the patient, it's guaranteed that you will not get too much of it on board. You sort of have your own kind of rate limiting exposure to it that will decrease the risk of dependence. None of this turned out to be true. You can absolutely overdose on codeine by accident. You can absolutely develop dependence with it. The problem is that you don't know which patients are going to be rapid converters of codeine into morphine. And so the argument now is just if you need a narcotic, just give morphine or hydromorphone. And the codeine, there's nothing special about it except the fact that it's maybe a little bit unpredictable how quickly it's going to work. Sub-anesthetic ketamine is people are getting increasingly comfortable using this for refractory pain. You can give it as an infusion for patients who have been to the hospital. Oral ketamine is also available. And then regional anesthesia can be really effective. This can be as an inpatient, but also as an outpatient. Some patients who have pain from avascular necrosis, for example, can benefit from having local injections of anesthetic, or other things that blunts the nerves from the area where the pain is originating from, and that can provide some relief too. So those are all sort of the options for a simple vaso-occlusive pain crisis. The complex acute pain syndromes are things that occur often with a pain crisis. And so you have to be aware when a patient comes in with pain that this may be accompanied by, or it is the precursor to something more life-threatening. For example, an acute chest syndrome, aplastic crisis, a sequestration crisis. Often, these symptoms are obvious. Patients with acute chest syndrome will have respiratory symptoms. They will have chest pain or fever. But if there's any suspicion, just get a chest X-ray. In aplastic crisis, patients will be extremely fatigued, pale. Your CBC will show them to be extremely anemic. Sequestration crises in children, these can be life-threatening. So this can actually show up as shock. Adults tend to sequester in their livers. They don't tend to go into shock as much, but they may present with abdominal pain, and then you'll see an elevation of their liver enzymes. Stroke, obviously, is a very serious complication of sickle cell disease. Tends to be ischemic in children or in older adults, but in young adults, you are as likely to see hemorrhagic strokes. And then hyperhemolysis is a particularly dangerous type of pain crisis that follows patients who have been transfused in the previous month. And in time, it will be very clear that hyperhemolysis is occurring because the hemoglobin is dropping very, very rapidly below the levels they were before they were transfused. But initially, their hemoglobin may be stable, and all this shows up as initially as a pain crisis. So when someone comes in with pain, you must get a transfusion history. Just a quick mention about sickle hepatopathy. So this is a form of intrahepatic cholestasis. So the liver gets very enlarged, the bilirubin gets quite high. There might be a small elevation of liver enzymes. Children can develop this sort of chronically, and it can be relatively benign, but in adults, it can be more insidious. It can progress into actual fulminant liver failure. This is one that is easy to miss because patients with sickle cell disease often have elevations in their bilirubin anyway from their chronic hemolysis. So you really have to look to see if is it conjugated or unconjugated. Hepatomegaly is often seen in patients with sickle cell disease, but is the liver bigger than it usually is? So it's a subtle diagnosis, but it's really important to catch because this one can get progressively worse. So all of these complex acute pain syndromes have been shown to benefit to varying degrees from transfusion, either a top-up transfusion or an exchange transfusion. Exchange transfusions are generally limited to patients who have more severe disease or their hemoglobins are already too high, i.e. they're already greater than 90 and you can't give them a top-up transfusion. But again, the huge exception to this rule is hyperhemolysis. Patients who develop hyperhemolysis, you must not transfuse them. It will only make them worse. And again, that's why it's so important to look for this when patients come in with a pain crisis, to find out, were you transfused in the past month? And if they were, to actually assess them carefully to see if they are hemolyzing the blood that they've just received. Chronic sickle cell pain syndromes, these are the ones that last for more than 3 months, and the pain is there more days than they are not. Avascular necrosis, osteomyelitis, vertebral collapse, ulcers, various arthropathies. All these things require some degree of imaging to diagnose. If you have done all the imaging you can, and you cannot see any lesion to explain that chronic pain that's there, particularly if the pain is sort of everywhere, if it's like the whole body is hurting all the time, then you might think about neuropathic pain. This is a difficult diagnosis to make, but once you have picked it up, it's really important to recognize that it requires its own type of therapy. Clues that a patient has developed neuropathic pain are that the opioids they are prescribed to treat it only work partially. They provide a little bit of relief, but the pain never fully goes away. And over time, it takes more and more narcotic in order to try to blunt that pain, and the pain just seems to get worse and worse over time. So there's this feeling of like, you're prescribing higher and higher doses of morphine. The patients, initially feel better, but then they come back feeling even worse. You give them even more morphine, it works a little bit, then they come back feeling even worse. This is a type of neuropathic pain that we sometimes refer to as opioid-induced hyperalgesia. And it's been shown to actually be mediated by mast cells. This has been shown in mouse models of sickle cell disease, but also in people. And mast cells can release substances that excite nerves and can lead to pain stimuli. And ironically, once those pain stimuli, reach the central nervous system, the narcotic can provide some relief from that pain. But the thing the narcotic is also doing is stimulating the mast cell. This is one of the great ironies here, is that the narcotics are both causing and treating the pain at the same time. And we know that morphine acts on mast cells because at low doses, mast cells cause itchiness, which is what we know is a major side effect of narcotics. But if you imagine if that sort of itchiness just kept getting intensified and intensified and intensified, eventually it becomes pain. So once you have the situation where you are stimulating the pain that you're also treating with the narcotics, you're sort of stuck in this kind of vicious circle. It's very hard to get out of that situation. There are all sorts of strategies, trying to decrease the use of narcotics as much as possible is one way to get there. Obviously, that's very hard because it will require having more pain in the short term. There are supportive therapies to try to relieve that. Suboxone can help with that. Methadone can help with this. Tramadol, non-opioids, non-pharmacological therapies, anti-seizure medications, antidepressants, things like cognitive behavioral therapy, mindfulness meditation. All of these things are really important. Key thing to keep in mind is that treating neuropathic opioid-induced hyperalgesia is going to take months and months. It's a long-term, difficult process. I have had patients who have made it through the other side and have got their lives back, but it takes a long time, and it requires kind of going through a period where you are learning to live with the pain to a certain extent and focusing less on eliminating that feeling of physical discomfort and more on trying to maximize your quality of life, more on sort of maximizing your functionality, what you can do, the relationships you can have, the activities you can participate in. And when that becomes the focus, it becomes a little bit easier, but it's a challenging situation to get into. And of course, one of the best ways to avoid this is to make sure that there are fewer episodes of acute pain that are getting you down this road, and decreasing the episodes of acute pain that requires just long-term comprehensive care for the sickle cell disease itself. Okay, I will stop there. Thank you so much.
Thank you, Dr. Pendergrast. And great presentation, very informative. I know we're going to move on to Q&A. We have a few questions in the queue. I'll go through them. So the first question is the same IPP provided in adult care at Ottawa Hospital? I trust this one is probably for Dr. Lamontagne.
Yeah, thank you. That's a great question. So IPP, I mean, you can create one and have it with you. The best would be if they would live in the electronic medical record. But we're small at CHEO, so we go with our notes, like our previous notes, we refer back. Our APS is called, and they have sort of all the notes from their previous admissions. But it would be great to have a document that could live somewhere where the ED physician could easily access it, and it could be as a guide, at least to get the ball rolling, so to speak, and the treatment initiated early, because we know that that's an area that we all need to improve on. So I don't have the perfect answer, but certainly this is coming down the pipe. As I said, there's also in the US, they're looking at an app that could be used by patients and would kind of communicate with the electronic or interface in some ways with the electronic medical record. So I know that's being looked at.
Great. Thank you, Dr. Lamontagne. Next question. I think this is for Dr. Pendergrast. It says patients know about sickle cell guidelines that should have them be seen within 60 minutes, and that's their expectation. But in triage, they're not considered acute, and they end up waiting 10 hours plus. What type of education needs to happen to bridge the gap of what is perceived as acute versus medical versus acute for the patient's experience who wants pain management that goes beyond what they use at home to manage their pain? Good question.
So this gets to the issue of self-advocacy, and I think it's important to know what the guidelines say, to know specifically about the triage score that sickle cell patients are supposed to be assigned, which is CTAS-2. And if you can use that term, CTAS-2 in the emerge, that may help. Unfortunately, it's still the case that you may need an ally, and sometimes that's going to need to be your regular doctor, your hematologist, and it's also understood that sometimes you can't get a hold of that person right then and there. And the best you can do at that point is circle back to your hospital, talk to their patient relations department, and say, "Look, I just had this experience. I know the guidelines say, and I wasn't treated according to them." That can make a difference, and sometimes that results in a request for an in-service, with the house staff at the hospital to teach about those guidelines about pain management. This presentation I just gave today is basically derived from a presentation that I give to hospitals frequently, talking about this is what you're supposed to do. So it's going to take some time, but I think we are committed to kind of getting the word out and educating people. For sure, not everyone has got the memo. It's just going to take a while.
Thank you, Dr. Pendergrast. We have one question for Dr. Pendergrast as well. Other than pain management, are there additional specific treatments for sickle cell hepatopathy to prevent further progression in adults?
So yeah, there are a growing number of new therapeutics coming out now. It's kind of an exciting time. Many of them are not licensed or approved for use in Canada yet. So they're still mostly available either through clinical trials or through like compassionate use or special access. But there are a lot of therapies out there. We haven't actually seen anything yet, to be totally honest, that has really beat hydroxyurea. We have trials that have been shown to be effective in patients who, maybe have not been adequately managed with hydroxyurea, like the hydroxyurea has not really helped them. But in terms of doing a head-to-head comparison, we actually have not seen anything yet that says, okay, this is now first-line therapy. So hydroxyurea is still our go-to. It's a medication we are so familiar with. Like, it's decades old now. We know everything about this drug. It's been studied so many different ways. We know it's safe. It's not that expensive. So that's one that's still underused, to be honest. Plus, there are all sorts of environmental triggers of sickle cell disease that we need to always be aware of and try to treat those as well. Make sure people are being fully vaccinated. COVID can be really nasty with sickle cell disease, for example. So really trying to encourage people to get fully covered for that. But there are new drugs, absolutely, that are coming out, new treatments. And it's just one of these things, you should see your doctor and say, what else is out there? Is there anything else I can try taking? There's things that are coming down the pipe.
Great. Thank you, Dr. Pendergrast. So we have a few minutes left. We wanted to make sure that everybody had a chance to also, let's say, provide feedback on the session. We sincerely appreciate your feedback because it helps us design the summits for the future and give feedback to the presenters as well as to the organizers to continue to provide these types of sessions for our audience. While I, let's say, provide the closing, the poll should be up on your screen if you don't mind providing your feedback for both presenters and the session. That would be really, really fantastic. But on behalf of SCAGO and let's say our audience, I'd like to thank both speakers for their wonderful presentations as part of this clinical track. as well as all the attendees and your thoughtful questions and your engagement. We will now close the session following the completion of the poll. You still have a few minutes to fill this out. And we hope to see you at the next session, which will start in, let's say, around 3 minutes or so. And that's a special plenary called the Follow-Up with Ontario Hospitals on Quality Care for Sickle Cell Disease. Are there still gaps to be addressed? And that starts, as I mentioned, in just a few minutes. But in the meantime, if you can finish the poll, that would be fantastic to provide feedback for all of us. So thank you again. And thanks again to Dr. Christine Lamontagne and also Dr. Jacob Pendergrast for your very nice presentations. Thank you.
Thank you.
Thank you. Have a great day.
Bye, everybody.